Bismillah ar-Rahman ar-Rahim. I am Osama Rajab, lecturer of neurology, Tanta University. We are going today to discuss what is called Introduction to Clinical Neurology. Our items today, we are going to discuss 3 items. First, mental state examination. Second is the speech, and third, language and speech. The third one is articulation. First of all, we can't proceed to examine or assess the mental state examination without knowing the conscious level of the patient. Because if the patient is disturbed and his conscious level is not intact, so we can't proceed to examine the mental state examination. So, first of all, we have to define what is consciousness. To address that the patient is conscious, he must be awake, aware, and respond in appropriate way to external and internal stimuli. To be awake, this is the function of the reticular activating system, which is part of the brainstem. To be aware, this is the function of the cerebral cortex, and to respond in appropriate way, this is the function of the frontal lobe. So, comatose patient or coma is defined as unarousable or unresponsiveness. So, we have what is called Glasgow Coma Scale to assess the conscious level of the patient. It has 3 items. The first item is eye-opening response. The second one is verbal response, while the third one is the motor response. Regarding eye-opening response, it has 4 items. If the patient has spontaneous eye-opening, he will score 4. But if he just open his eye secondary to verbal stimuli, he will get 3. If the patient open his eye only secondary to painful stimuli, he will get 2. If I have no response to painful stimuli, we will score 1. The verbal response, I ask the patient a question, like where are you from? Or what are you doing here? If the patient is oriented and gives the right response, he will be scored 5. If the patient is confused and gives us a wrong answer, he will be scored 4. If the patient can't form sentences and just give words, will be scored 3. If the patient can't form words and just I hear sounds which has no meaning, he will be scored 2. If I get no response, it will be scored 1. Regarding motor response, I ask the patient a motor command like that: raise your hand, raise your leg, close your eyes. If the patient performs these commands well, he will be scored 6. If I have no response, so I will apply a painful stimuli to any part of his body. If the patient can localize the pain by his limb, he will be scored 5. If the patient can't localize but just to draw his limb from the pain side, he will be scored 4. If the patient just flex his limb second for pain, it will be scored 3. But if the patient extended his limb, he will be scored 2. If he has no response, he will be scored 1. So, the fully conscious patient should give a score of 15, which equals 4 plus 5 plus 6. And the deeply comatose patient will be scored 3, which equals 1 plus 1 plus 1. If the patient is fully conscious, so I will proceed to my assessment of mental state examination. The mental state examination has many items. These items include the appearance, the mood and affect, the speech, thought process and the content, orientation, concentration and attention, memory, abstract thinking, insight and judgment, and spatial perception. The first item is appearance. I am looking for assessment of nutritional state examination. If a patient is cachectic He may be suffering from a chronic debilitating disease such as cancer or neoplasm. The posture of the patient. If I facing, for example, a patient with a flexed attitude, he may suffering from Parkinson's disease. The patient dress and grooming, the way he is taking care of himself. If patient has a self-neglect, he may have a dementia or depression. The features of the patient may be characteristic of some illness, such as Down syndrome or chronic hepatic disease. The facial expression of the patient. If I facing a patient with unmasked features, no facial expression, may he suffering from depression or Parkinson's disease. Irritability. If my patient is irritable, he may suffering from post-ictal state or, for example, pre-hepatic coma. The mood and the affect. The mood is defined as the sustained emotional experience for a period of time. I can ask it to the patient, how do you feel most of the days? Are you euphoric? Are you elated? Are you depressed? Then the affect is what appears in patient face during interview. The patient affect is defined in a following term. He may be expansive, or euthymic, normal, or planted. I can't see any facial expression such as schizophrenic patient. Speech. Regarding speech, I document information on the quality of the patient's speech, the quantity, the rate, and the volume of the speech. The speech here doesn't assess the language or the way the patient speaks, which is articulation. Is patient has poverty of speech, speak too little? Is the patient speak in a slow rate or rapid rate? Is the patient volume is low or high? If the patient, for example, has a low rate of speech and the volume is slow, he may suffering Parkinson's disease. Thought process and content. The thought process can be described in the following term. What is called loosening of association, such as asking the patient a question and he give me an irrelevant response. The flight of idea. The patient, when I ask him for something, he always give me an answer, then change his topic to another answer. Word salad means that the patient has no connection between his sentences. He gave me a sentences, then another sentences not related to the first one. The neologism means that the patient create his own language with a special word that has meaning only the patient know it. The thought blocking, which is called that while the patient is going to speak, suddenly he stops speaking. He has nothing to continue. His thought is blocked. This is a characteristic of patient with schizophrenia. This neologism also for schizophrenia, or the salad for schizophrenia, but flight idea is related to patient with bipolar disorder, especially mania. Thought process and the content. Thought process and the content. Here we are searching what is called hallucination and delusions. Hallucination means that the patient has a sensory experience in the absence of the stimuli. I can assess it by asking the patient these two questions. Do you hear voices when no one else is around you? If he says yes, so he is experiencing a auditory hallucination. Second one, can you see things that no one else can see it? If he says yes, this means that he has a visual hallucination. Second part, to assess if the patient having a delusions. Delusions is defined as a false fixed beliefs that can't be corrected by the logic and not accepted by the people with the same cultural level. For example, I can ask him this question: do you have any thoughts that other people think These are strange. Do you have any special power or ability? Do you think the television or radio are giving you some special message? So, if the patient says that the television sent me a special message, this patient has delusional of reference. Okay? If the patient thinks that some people are persecute him, this so maybe have a delusion of persecution. If the patient says that some security agent implanted in him a device or electronic chip to follow him and control him, so the patient has delusion of control or possession. Orientation. Orientation. The person should be oriented to 4 items, which includes the person, the place, time, and situation. Simply, I ask the patient what is your full name. If he gives the right response, he is oriented to himself and his person. Or I ask him, what is my job, who I am. If he says you are doctor, so he is oriented to the person. The second question, I ask him, where are you now? He says that I am in the hospital or the clinic, so this is the right response. Then I ask him about the date and the time now. If he gives the right response, he is oriented to the time. The last one, I ask him, do you know why you are here? If he says that I'm here for medical assessment or seeking medical advice, so he is oriented to the situation. Then we assess concentration and attention. Concentration and attention, we can assess it what is called serial 7. I ask the patient to subtract 7 from 100 and then repeat it. 7 from 100 equal 93. So I ask him subtract 7 from 93 and so on. Or I can ask the patient to spell the word or week forward and backward. Memory. This memory to evaluate the patient memory. He had to respond for remote memory, recent memory, and immediate memory. For testing remote memory, I ask him, what was the name of your first grade teacher, for example. For recent memory, I can ask him, what did you eat for your dinner last night? For immediate memory, I give him 3 words, pen, chair, flag, or any other 3 words, and ask him to repeat them after 5 minutes. This is called an immediate memory. The abstract thinking. The abstract thinking to assess 2 points. Can the patient find the similarities between things, and can he understand the proverb? To assess if he can find these similarities, it is simply to ask him what is the if an apple and orange, what are they similar how these items are alike. The good response, he will say that both are fruits, but the poor response, he will say they are rounded. If this say these items are round, so the patient has concrete thinking or non-abstract thinking. To understand the proverb, I tell him a proverb. If the patient gives the literal meaning of the proverb, so he has concrete thinking. But if the patient can explain the proverb and the meaning behind it, so he has abstract thinking. Insight and judgment. Insight is ability to patient to be aware of his illness. and understand his illness. So the patient can admit that I have a mental illness and I come here for medical assessment, for medical evaluation. So the patient is incited. Imaginary, the judgment of the patient. I tell him imaginary scenario. If you are lost in a city and you have money, how will you act? For example, the spatial perception. It is a test of both parietal and occipital function. For example, I will ask the patient to draw a clock and put the pointer to the hour 10 and 10 minutes. We notice here the patient can't place the number correctly. He is ignoring some spaces. This means that the patient has a spatial perception problem and the patient has parietal and occipital lobe dysfunction. The second item in our lecture today is the assessment of language. Language is defined as the ability of the patient or the person to express his own ideas, either in spoken language or written language. This is a neuroanatomy of language. We have an area here. This area is called vernix area. Vernix area is related to the posterior superior part of the temporal lobe. Here we can understand the language. When we hear a word or sentences, we can understand its meaning in this area of the vernix and this area of angular cortex. To speak, produce words, we need what is called the Broca's area, which is related to the lower frontal lobe. This bundle of fibers is called the arcuate fasciculus, which connects between the Broca's area and the vernix area. To assess language, we assess this item. Spontaneous speech asks the patient to speak freely and fluently about anything. Naming, I choose a patient different items and ask him to name it. Auditory comprehension, I told the patient to order and assess if he can understand these orders or not. Repetition, I ask the patient to repeat words behind me. Reading and writing, I ask the patient to read a piece of paper and writing, I ask the patient to write sentences following me. If the patient has a lesion affecting the Broca's area, this area, which is responsible for production of speech and language, but the vernix area is intact, so the patient can't speak fluently, but he can understand what I told him. So the fluency will be affected, but the comprehension will be intact and other item will be affected. On the other side, if this lesion affecting this vernix area, so the patient can't comprehend but can speak fluency and all these items are affected. If the lesion affected the articulate fasciculus but the vernix and the Broca's area are intact, so he can speak fluent and he can comprehend words but can't repeat or name object, but reading and writing are intact. If a massive lesion affecting all this area, including post-vernix and Broca's area, we have what is called global aphasia. The patient can't speak fluently, can't comprehend, can't repeat, can't name, can't read, or can't write. Articulation. This is the last item in our lecture. Articulation means that the ability of the patient to pronounce or articulate in a normal way, so I can understand his word. All parts of the neuroaxial systems are affected or are involved in the process of articulation. So if the patient has a problem with his bilateral pyramidal tract or corticospinal tract, the patient have difficulty in the letter with P, B, D, and R. The patient appears to speak from the back of his throat, and this is called spastic dysarthria. For example, the patient says that Bismillahirrahmanirrahim. The patient has difficulty with opening his mouth due to spasticity of the tercoid muscle. So he is speaking with difficulty as speaking from his back of the throat. If the patient has a lesion in the extrapyramidal system, such as Parkinson's disease, the patient will have what is called hypophonia and monotonous speech, like that. Bismillahirrahmanirrahim. If the patient have ataxic dysarthria due to lesion of the cerebellum, normally we are speaking during expiration, but due to incoordination between the muscle of the breathing and the muscle of articulation, patient will have inspiration during the expiration, during his speaking. So the patient's speech will be irregular, slurred, and the patient has explosive quality and scanning. Scanning means that he will interrupt the words into parts. For example, Alhamd Allah Rabbil Alameen. So the patient divided the word into syllables, and the exclusive character he is taking inspiration during his speak. If the patient has a lower motor neuron lesion, so the patient with facial paralysis, he will have a difficulty with labial letters such as P, P, and W. If the patient has tongue weakness or paralysis, the patient will have difficulty with pronouncing letter S, T, X, and Z. If the patient has palatal paralysis due to weakness of the tensor furlae, the patient will have a nasal tone of speech, like that. Alhamdulillah Rabbil Alameen. Okay? So, this is the end of our lecture. I hope you enjoyed it, and see you in another lecture, inshallah.